So we'll start with the case presentation. I thought it will be a good idea to make it more interesting. Let's start with the case. So this was a 55-year-old businessman who collapses at work. This scenario may have been witnessed by a lot of us. So he was witnessed by his colleagues who found him pulseless. So they initiate a CPR and call 101. The emergency medical services arrive around 5 minutes late. Sorry, the screen, yeah. They confirm the pulseless activity and place the patient on a monitor, in which they found that he's in VFib. So standard ACLS protocols are initiated. That is, patient is shocked, intubated, and then transported to the closest emergency department. He arrives in the emergency department 7 years post cardiac arrest, already received 2 doses of epinephrine and 1 dose of atropine, has received 2 shocks, and currently is in pulseless electrical activity arrest. Next, please. In the ERP, there is conferment of the ET tube placement. Rhythm is PEA, which is pulseless electrical activity, and they perform a quick bedside echo, all while continuing the CPR. The echo shows that the cardiac activity is there, that is, the cardiac motion is present. So he's given another dose of epinephrine atropine. By 6 minutes of his arrival in the ED, he achieves ROSC, which is return of spontaneous circulation, and is reverted back to normal sinus rhythm. Now, ICU is consulted. Next. When he comes to the ICU, his vital signs are 112 of heart rate, respiratory effort is poor, blood pressure MAP is 48, rectal temperature is 36.5, glucose is 17.8, and saturation with ET placement is 100%. Now, quick examination reveals ABCDE, which reveals airway, ET in place, B is breathing with positive EtCO2 capnography, circulation, which he has a MAP of 48, GCS of 3, absent gag, corneal, and pupillary response, E, nothing, and there is no cough edema. In past medical history, 30-pack years of smoking, not on any medication, no drug allergies. He is known to travel abroad frequently. Next. So this is the ACLS algorithm, which we all know that first we have to verify the scene safety, responsiveness, shout for help, activate the EMR, get an AED. After the AED, we see whether the patient has shockable rhythm or not shockable rhythm, breathing present, not present, CPR. So all we already know. Here we'll have more, I'll put more concentration on how to manage these patients in the ICU after they have achieved their spontaneous circulation. Next. So this is the cardiac arrest algorithm, in which the main focus is the reversible causes. Now, after you have achieved the ROSC, you have to treat what caused it. So the reversible causes are 5H and 3Ds, which include hypovolemia, hypoxia, acidosis, hypo or hyperkalemia, hyperthermia, tension pneumothorax, cardiac tamponade, toxins, and thrombosis, which can be pulmonary or coronary. These are the main causes of cardiac arrest. So you have to search for them. Next. This is then again the algorithm, in which the continuous CPR, which we already know is very important. You have to push hard, push fast, minimize interruption within the compressions, avoid excessive ventilation, change compressor every 2 minutes. If there is no advanced airway, then you have to use 30:2 compression ventilation ratio. This is all for your revision. We're not going to put much effort on this. Next. So now here comes the question. Define post-cardiac arrest syndrome and its 4 pathophysiological components. Now, What is this arrest syndrome and what are the main components? Next, please. We are going to learn this. So the definition is, it is a unique and complex combination of post-cardiac arrest brain injury, post-cardiac arrest myocardial dysfunction, and an ischemic reperfusion systemic response. So it includes brain, it includes myocardium, and it includes a systemic reperfusion response. It is often complicated by a fourth component, which is unresolved pathological process, which caused that cardiac arrest. Now, all these three initial things are caused post cardiac arrest, but the fourth pathological process has already set in before this arrest and is often the leading cause of the arrest. So we'll study the phases for the therapy. Now, the immediate post-arrest phase could be defined 20 minutes from the return of spontaneous circulation, which is called the immediate phase. Early post-arrest phase is from 20 minutes to 6 to 12 hours, when early interventions might be effective. Intermediate phases from 6 to 12 hours to 72 hours, when injury pathways are still active and aggressive treatment is instituted. Finally, from 3 days till disposition, it is considered as recovery phase, when prognostication becomes more reliable and the ultimate outcome is more predictable. That means after 3 days, you can say whether with some reliability, whether the outcome will be good or bad.